Hello, and welcome to the lecture on active and passive euthanasia. We are going to be going through the Rachel's paper, as well as some of the material in the Philippa Foot paper in this lecture. Before I get started with the philosophical bit, I want to take a little opportunity to introduce the topic of euthanasia a little bit more fully, talk about the forms of euthanasia, and then introduce Rachel's main idea. So, I'm sure that many of you know the term euthanasia comes from the Greek for good death. It's defined as the act of killing or permitting the death of a hopelessly sick or injured individual in a relatively painless way for reasons of mercy. That is a good definition because it mentions either killing or permitting the death, right? And that, as we will see, is going to be the distinction between what is called active euthanasia and what is called passive euthanasia. It also mentions that the individuals to whom euthanasia is administered have to be hopelessly sick or injured, that the euthanasia is relatively painless, and, just as importantly, it specifies what the motives are for reasons of mercy. So the motive is taken to be important to identifying whether or not an action is euthanasia, which common sense tells us is going to be right. If someone murders someone for the purposes of getting their money, doesn't count as euthanasia just because the person is hopelessly sick or injured and you do it painlessly. So euthanasia, typically practiced in order to bring an end to unnecessary pain, to preserve the dignity of the patient, or to preserve the integrity of the patient's overall life. So obviously unnecessary pain is clear. Dignity refers to our ability to respect ourselves and to feel like we are respected by other people. Of course, what constitutes dignity is going to differ quite a bit from society to society. There are some fairly universal things, but depending on the culture, also depending on one's individual lifestyle, one's individual achievements, one's individual social circle, and so on, dignity might look quite different. I mentioned last time that there can be narrative constraints on a person's enjoyment of their life. People like to feel that they're having a narrative that goes a certain way, and that can sometimes lead to different ideas of what would be undignified. If you've been, a massively powerful monarch or something, you might consider it to be beneath you just to have to ride the bus, right? I ride the bus all the time. I've never seen a massively powerful monarch, but I don't know what to look for. But, so the point is that depending on where you've been, where you think you're going, these kinds of ideas of dignity can change. Ideally, we have some minimum stipulated definition of what constitutes dignity. Usually involves things like being able to feed yourself, being able to go to the bathroom by yourself, although some people are content even without those things. Right? So it can differ from case to case. Integrity of the patient's overall life, that's something a little bit closer even to the narrative idea that I introduced last time, that someone might want to have some control over the shape of their life. What does their life look like as a whole story? I think it's good to think of it as almost like a novel. And controlling how the novel ends, or how it doesn't end, can sometimes be an important consideration. Euthanasia isn't just practiced for reasons, of course, that have to do with the patient. It can also be practiced out of a desire to avoid what are considered to be pointless expenses, or pointless suffering on the part of loved ones. Right? So ideally, when we say this, this means that the patient themselves has these motivations. Right? They don't want to make others pay for them to have a life of suffering or an undignified life, a life that they don't really want anyway. Or simply because doctors and loved ones don't see a point in keeping the patient alive any further. Now, generally speaking, and I think Canada is a unique case because Canada is currently in the process of reviewing and revising its laws on euthanasia. Euthanasia also generally requires the presence of a terminal condition. And this has been a matter of debate in the Canadian Parliament in recent years, the last year especially, last 2 years, whether or not that condition, the requirement of a terminal illness, an illness that will lead to your death in the foreseeable future, should be there. And it's in fact been determined to be unconstitutional to have such a restriction. Now, the worry, or in some cases, the thing that is looked forward to by some advocates of euthanasia, is that individuals with severe mental illnesses that aren't going to kill them might be able to access euthanasia. So if someone is severely depressed, severely schizophrenic, it can be the case that that person might have access to euthanasia. And there's a great deal of debate about whether that would be a good thing. So I've mentioned already the distinction between active and passive euthanasia. We'll go over it again in a couple of seconds. This is a different distinction. This is the distinction between voluntary, non-voluntary, and involuntary euthanasia. Pretty obviously, voluntary euthanasia is when the patient consents. The consent can be concurrent, meaning it happens immediately before the euthanasia is administered. It can be also prior, when someone has an advance directive. Someone decides, because they foresee losing many of their capacities, and in particular losing the ability to consent to euthanasia because they know that they're going to lose their rational faculties, that person can sign an advance directive, right? Saying either don't revive me if something happens, or take steps to end my life if that is an option where they are living. The cases of concurrent and prior consent introduce different kinds of considerations. Right? You can see why prior consent would be a lot more difficult if you think about it. Because imagine someone has signed an advance directive and they say, if I am debilitated when this condition reaches this point, I would like not to be resuscitated. Imagine that has happened. Now imagine that the individual that signed that appears to be quite happy, appears to be very happy, appears to be, relatively speaking, content. Very happy is pushing it, I'm sure. But they indicate some kind of contentment. Now the question is, do we follow the advance directive, or do we go with what appears to be what the patient might like given their current handling of the situation? It's a big issue. There's also non-voluntary euthanasia. This occurs when a patient's consent is unavailable, either because the patient is an infant or a child. Rachel talks about instances of children born with Down syndrome that are allowed to die due to an intestinal blockage, or because the patient has become incompetent and hasn't left any kind of advance directive. There's a lot of high-profile cases that happen in the United States where someone is in a coma and they are not going to come out of it, and they are more or less vegetative, and their family members decide that that person should be taken off life support. That would count as non-voluntary euthanasia. Finally, there's involuntary euthanasia, which occurs against someone's will. This is typically considered murder. It says it may sometimes be thought to benefit the patient. It's still murder, right? So involuntary euthanasia is not something we're going to be talking about because it's a crime and should be. So the distinction between active and passive euthanasia is the one that we are going to be looking at in the next couple of lectures. In particular, we're going to be looking at the question of whether there is any morally relevant difference between these two practices. Whether the fact that a given action is an action of active versus passive euthanasia makes a difference to whether that action is morally right, morally permissible, morally obligatory, and so on, morally impermissible. The legal systems of many countries do see a difference. Passive euthanasia, we'll see, is fairly widespread. Active euthanasia only occurs in 7 countries at the moment, and a couple of U.S. states. Actually, quite a few at this point, I think. Maybe 10. So, what's the distinction? Well, passive euthanasia means that a death is deliberately brought about by an omission or discontinuation. So, when passive euthanasia occurs, someone dies. They die because somebody involved in the treatment intended that outcome. It wasn't an accident. And the death would have been prevented had somebody done something, right? So that's what the omission or discontinuation refers to. So someone omits or discontinues resources or procedures that are necessary for continued life. The case of an infant with an intestinal blockage that isn't cleared would be an instance of passive euthanasia. That would be failing to provide some necessary operation that could easily have been provided. Another example would be simply withdrawing a feeding tube or a respirator. As we say in colloquial discourse, pulling the plug. So the important part here is, again, that no one is doing anything, or at least it doesn't seem like they're doing anything, because when we get into the Rachel's is going to argue, look, not doing something can be a kind of doing something. Furthermore, Foote is going to point out that perhaps the active and passive distinction that we operate isn't precise enough to get the right answers in all cases. Foote points out that there doesn't seem to be a difference between turning a respirator off, which looks like an action, and here is counted as an action, by the way, right? Withdrawing, that would be an action, or failing to turn it on one morning. Let's say you have a respirator that has to be turned on every morning. If you fail to turn it on, that would look like it's more passive than actually turning it off, but most people don't see a big difference, at least in the case of someone who's terminally ill. So that's passive euthanasia. It's a distinction that a concept that looks fairly straightforward, but as you can see from the list and what I just said, there are some difficulties because withdrawing a feeding tube, that looks like an activity, right? But it's going to be counted as passive. Philippa Foote is going to try to give us a better criterion for dividing cases. Active euthanasia happens when a death is deliberately brought about by some positive action that someone takes. A positive action that ends a life that would otherwise have continued. Examples would be injecting a patient with a lethal dose of a drug. So that's active. So basically, in passive euthanasia, something has to be done to keep the patient alive. Passive euthanasia means that you stop doing it. And that also goes for the respirator withdrawal. So the respirator has to be there for the patient to go on living, and we just take it away. Active euthanasia occurs when, if no one does anything, the patient's going to live on. Something has to be done to cause the patient to die. That's why we have active versus passive. There's also a third category, which is worth mentioning, which is assisted suicide. And that's when a doctor provides the means to someone to allow them to end their own life, but doesn't administer these means themselves. So a doctor might provide someone with a prescription of drugs that they know are going to be fatal because the patient has requested it. There are suicide bags that a patient can put over their heads to use to deprive themselves of oxygen. These would be considered assisted suicide, right? It's suicide because you are killing yourself. And it's assisted because someone has provided the means to you. In many countries, the legal status of assisted suicide is the same as active euthanasia, meaning it's illegal. But assisted suicide is often thought of as a middle ground between passive and active euthanasia, as a middle ground between these two other options. It doesn't require doctors to directly cause death. It might, therefore, help doctors to avoid difficult feelings of guilt. It might also make the patient feel more in control. Of course, with that added control, we're going to get possibilities for mistakes that can be deeply traumatic, painful. There's also perhaps a certain loneliness. There's also perhaps a certain fear of having to do this oneself. So, in terms of legality, passive euthanasia is legal and considered routine in most countries. Typically, it takes the form of an advance directive or a do not resuscitate order. So, you have a living will, you fill out, you say, if I need resuscitation, I don't want it. Active euthanasia is legal currently in 7 countries: Netherlands, Belgium, Luxembourg, Spain, New Zealand, Colombia, and Canada. It's legal in more states than those 3. Those were the first 3, I think. If you need more information, you can look it up. When I taught this last time, the number of countries that provided active euthanasia was only 5. Since the last time I have taught this class, Spain and New Zealand have been added. Assisted suicide is currently legal in Switzerland, Germany, Netherlands, several US states. Actually, come to think of it, I'm sorry that I didn't figure this out, but if you're interested, you can do some research. I believe that, in fact, the active euthanasia list is perhaps complete, but I was thinking that if you combine those, that was the list I was thinking of. So, anyway, while the AMA reconsidered the use of active euthanasia and assisted suicide in 2018 and again in 2019, its position on these issues remains more or less the same as the one found in a 1973 statement. So, during the last couple of classes, Velleman mentioned the idea of a professional canon, meaning a rule book which is supposed to bind practitioners of a particular discipline, of a particular profession. And so if there's a professional canon, that means that people that are accredited by the relevant institutions to practice the profession have to follow those rules. Okay, and these organizations meet and discuss pressing issues annually, and they often revisit the question of euthanasia. The position hasn't changed. The numbers have, because they vote on these things. Certain matters of wording have changed, but the position remains the same. So, what the American Medical Association, the AMA, says is the following: the intentional termination of the life of one human being by another, mercy killing, this would be active euthanasia, is contrary to that for which the medical profession stands and is contrary to the policy of the American Medical Association. The cessation of the employment of extraordinary means to prolong the life of the body when there is irrefutable evidence that biological death is imminent is the decision of the patient and or his immediate family. The advice and judgment of the physician should be freely available to the patient and or his immediate family. So basically, this is telling us that active euthanasia is against the policy of the American Medical Association, and it is against the policy of the American Medical Association because it stands contrary to what the medical profession stands for. Right? The medical profession is being defined here as a healing profession, a profession that prolongs life, that heals. And so the idea that a doctor would be actively killing and using their medical expertise and privileges to that end is being said here to be contrary to the aims of physicians at large. Passive euthanasia is put within the decision-making capacities of the patient and the family. The doctor is supposed to be offering advice and judgment freely, but ultimately the decision rests with the patient and their families. So I mentioned that this issue was revisited in 2019. A statement was put out. The revisiting didn't substantially change the position from 1973, but in the statement, there was a certain softening of language and a greater attempt to recognize that the medical profession is fairly divided about this issue. Okay, so the actual policy statement didn't change, but there were some additional statements made that were meant to capture the possibility of reasonable disagreement. There were also statements made that were meant to capture points of agreement among doctors who otherwise disagreed on the issue of active euthanasia. On this slide, we have one such statement. Patients and physicians too often still do not have the conversations they should about death and dying, and too few patients are aware of the range of options for end-of-life care, raising concerns that many patients may be led to request assisted suicide because they don't understand the degree of relief of suffering state-of-the-art palliative care can offer. Patients who in other respects hold very different views participants who in other respects held very different views concurred as well that patients may be vulnerable to coercion, particularly patients who are in other ways disadvantaged, and expressed concern in common that forces external to medicine could adversely influence practice. So here we're getting two main points being expressed. First of all doctors who are part of the association, who have participated, tended to agree that there is too little information about the quality of palliative care that is meant to reduce your suffering. And the thought is that if individuals had more information about what medicine can do now to keep one from suffering, fewer people would request assisted suicide. So there's a general desire to provide more information than is currently provided, which I think is obviously going to be a point of agreement. Clearly, if someone is making a decision, a family is making a decision in conjunction with a person, we want them to have as much information as possible because we respect their rational decision-making capacities, and so we want to give them the information they need to make a rational decision. The other point expressed here is quite similar to the kind of worry that Velleman has. Patients may be vulnerable to coercion. Velleman doesn't talk specifically about coercion. Coercion would mean there is a bit of pressure applied to patients to die. I suppose Velleman does. Right? Coercion just sounds like a word that's a little bit more extreme than what he describes. But in some cases, Velleman, I'm sure, is worried about coercion, particularly in patients who are in other ways disadvantaged. Right? So that's exactly what Velleman pointed out when he said, look, when someone is bedridden and terminally ill, social relations with family members and friends are one of the few bright spots in their lives, and therefore the effect of some feeling that they are not being respected, that they are being viewed as cruel or irrational, can cause a lot of harm and can make an individual make a decision that perhaps they wouldn't have otherwise made. And then, of course, forces external to medicine. These would be things like financial pressures. These would be things like emotional pressures. Okay, so this is the updated position. It is unclear what will change in the AMA position or when. There is still a fairly divided set of participants. So the AMA statement from 73 is one that Velleman is likely to agree with. That's one thing to stress after having done that paper. So to move into the Rachel's paper, the first thing I want to talk about is actually the thesis that Rachel's rejects. This thesis is called the moral difference thesis, or at least that's what I'm calling it. And this is what Rachel's is arguing against in his paper. The moral difference thesis holds that there is an intrinsic moral difference between active and passive euthanasia. In particular, active euthanasia is much worse morally than passive euthanasia. Intrinsic is a fairly common word in philosophy. It basically means that the difference that there is belongs to active and passive euthanasia in virtue of what they are. The opposite of intrinsic is extrinsic. So a car, you could say, intrinsically has an engine because part of what it is to be a car is to move, and to move you need to have an engine. So having an engine, we could say, is intrinsic to a car, perhaps any vehicle. Of course, there's surfboards, I suppose we could call those vehicles, but for being a car, having an engine is intrinsic. Being red, we could say, as extrinsic, okay? Because you can be a car and not be red. So what's being claimed here is that there is a difference morally between active and passive euthanasia, and that difference isn't just some accidental thing that occurs in some cases, but in fact inheres in active and euthanasia in virtue of what they are. In virtue of what actions they involve, there's a difference. So that is the moral difference thesis. This is going to be what Rachel's is arguing against. Now, it's important to understand what the moral difference thesis itself is not saying and what it is saying. So what the moral difference thesis is not saying is that active euthanasia is always impermissible. Okay? It doesn't say that. It just denies that the two forms of euthanasia are morally equivalent. So this thesis doesn't tell us that in all cases active euthanasia is going to be impermissible. It is, however, ordinarily interpreted in this way by the medical and legal professions. Now, when I say that, I don't mean that they've seen the formulation that is here. It's just that they do, as we saw in the AMA statement, think that there's a difference between active and passive euthanasia, and that active euthanasia is worse. And so, of course, it's more likely to be impermissible. Now, a big contention of Rachel's is that the moral difference thesis is false. that it is false. That's a theoretical philosophical contention. Rachels isn't just concerned with the moral difference thesis because he thinks it's false, however. There's a practical upshot in the lives of many people that hinges on what we think about the moral difference thesis. In practice, Rachels contends, the moral difference thesis often leads to unnecessary physical and psychological suffering that could easily be mitigated by active euthanasia. So the key word here for Rachels is going to be unnecessary, because people who think that the moral difference thesis is true, they're still going to have to admit that the moral difference thesis often leads to physical and psychological suffering. They might hope that there can be some avenue for passive euthanasia because they believe in the moral difference thesis and therefore they're unwilling to provide active euthanasia. But the person who holds the moral difference thesis to be true is not going to call the physical and psychological suffering unnecessary. It's going to be necessary morally speaking, because morally right action demands that we not actively euthanize this patient. So to illustrate this practical upshot of accepting the moral difference thesis, Rachels imagines a patient undergoing incurable throat cancer that causes severe pain. So he's trying, in particular, to get at the fact that the moral difference thesis causes preventable suffering. So a patient has incurable throat cancer. It's severely painful. The patient requests death. The doctor has three options. Number one, active euthanasia. Administer a lethal injection so that the patient dies immediately. 2, withdraw life support so that the patient dies in 24 hours. 3, do nothing so that the patient dies in 5 days. Now, these are not options in the sense of legal options in many places. And of course, if you believe the moral difference thesis and you want to be moral in your action, you're going to only think that 2 of these are options. So the doctor is at very least going to prefer option 2 to 3. Right? So we're not thinking about active euthanasia yet. But the claim here is that doctors who are generally okay with passive euthanasia are going to prefer option 2 to option 3. Why? Well, because the patient is in severe pain and we want to alleviate that, even if that means that the patient dies more quickly. That's what the patient wants. So it is preferable to withdraw support so that the patient will die within a day, as opposed to dragging out the pain and having them live 5 days longer. What Rachels points out is that those who believe in the moral difference thesis are going to prefer option 2 to option 1 in most cases. Thus, the patient is going to suffer more than the patient would have suffered otherwise. The idea here is that we make a moral decision on some grounds. What Rachels wants to make us see, in part, is that the same grounds someone might have for preferring option 2 to option 3 are also going to be grounds or reasons for preferring option 1 to option 2. Because ultimately, our aim in preferring option 2 to option 3 is the alleviation of suffering. And if our goal is to alleviate suffering, Rachels will say, then why don't we go for 1? We're already making a decision that death is preferable to suffering. Earlier death with less suffering is preferable to later death with more. Once we've decided that those are the way the outcomes look in terms of preference ranking, why wouldn't we, therefore, move from option 2 to option 1? If we care about the total time suffering, and that's our goal in moving from 3 to 2, Rachel thinks it's, in a way, a kind of irrelevant difference to draw between 1 and 2. At worst, we might even call it a kind of superstition. So, this moral difference thesis, first of all, practically speaking, leads to what Rachel thinks is unnecessary suffering. Rachel also has another complaint, though, and that is that moral difference leads to what he calls questionable compromises. And what he means by that is it leads to choices that are difficult to defend given the underlying values that motivate them. This is exactly what I was saying on the last slide. Sometimes I get ahead of myself. So if we consider the doctor's options in the throat cancer case, we see that we have immediate death, death in 1 day, and death in 5 days. To prefer option 2 to 3, but then not go to option 1, is what Rachel calls a questionable compromise, right? It's a compromise between active euthanasia and nothing, but it's questionable because it's hard to defend given the underlying values. If we prefer 2 to 3, it must be because we have a certain value. We think that suffering is bad. And it must be, therefore, that we think that suffering should be mitigated whenever possible. If that's the case, we should also prefer 1 to 2. Now, those of you who have done some ethics before might recognize the kind of reasoning that Rachel seems to be engaging in here as what we would normally call consequentialism. Consequentialism is the view that the moral status of an action depends on the consequences it brings about. Okay, we'll go into greater detail about this later, but the basic idea of consequentialism is a structural one. It's a claim about how we determine what actions are right and what actions are wrong. The consequentialist wants us, first of all, to think about what we could call outcomes or states of affairs. And they want us to have some ranking of those outcomes and states of affairs according to their value. So there are some outcomes that are really good, some that are really bad, some that are in the middle. The consequentialist then says, look, once we've got our values, we're going to provide a definition of right action that is parasitic on, relies on our values. Because the right action for a consequentialist is going to be whatever action best promotes value. So once we have our list, as soon as we can bring about the most value available in a situation according to our list, that becomes the right action. Right? So that is the kind of reasoning that is happening here. Right? So the idea is we've clearly, if we prefer 2 to 3, that has to be because, or Rachel's is thinking it has to be because, we think that there's an extreme disvalue attached to human suffering. And of course we all do. And so that is why 2 is a better option than 3, because there's an extreme disvalue attached to suffering. And so the right action of those 2 options is going to have to be 2. But if 1 is also an option, Rachel's is saying here, well, look, the same value, the same need to alleviate pain, to reduce the amount of pain in the world, that's also going to be the reason to prefer 1 to 2. Now, if we aren't consequentialists, we're probably going, not necessarily, but probably going to reject the move from 2 to 1, because we will think that we don't figure out what actions are right only by looking at what consequences they bring about. Instead, we look either primarily, also, or even only in some cases, to some list of rules or principles, and that we have to follow those rules or principles even when we might bring about better consequences by following some other set of rules or principles. So this is called deontological approach to ethics. It's a deontological approach to ethics. Deontological coming from Greek word for duty, deon. It is necessary. It's a way that you can make a sentence that says it is necessary that, deon, and then add verb and some objects and subjects. Deontological views basically deny that the only thing that's relevant to figuring out the moral status of an action is the consequences it will bring about. Okay. Now, we talked quite a bit about rights so far. Rights sit more comfortably within a deontological framework than they do within a consequentialist one. And having seen what I just said about consequentialism, you can imagine why that might be the case, right? Because there are going to be many cases that we could imagine anyway, where we can bring about better consequences for everyone globally by doing something to someone that seems like it might violate their rights, right? The common cases are, imagine that there is a mob that demands justice over a really horrible crime, say a terrorist attack. Many, many people have been killed, thousands. People are really angry. If you don't frame someone for the crime and execute them, there's going to be a disaster, huge riots, violence, massive social disorder, and a lot more death. So the consequences of falsely accusing someone and punishing them for the crime are going to be, we can stipulate, much better than the consequences of not doing that. Consequentialists are going to feel quite a bit of pressure, therefore, to identify the right action in that case as the one that involves the false accusation, the framing, and the execution, because that has much better consequences. If we don't like that answer, it's going to be because we will think that the rights of the individual who has been falsely accused have been grievously violated. Right? You can't do that to someone. That is a claim about rights, and it is a claim, if we believe in rights, that we're going to think we need to respect, even if the consequences of not respecting it are drastic. Right? So even if not framing this person means far more death, if you're a strict deontologist, you're going to say, you know what, so what? There's lots of things that you'll say in response to why that's the case. One of them will be, look, I am not killing this person unjustly if I don't frame them and execute them. Other people might kill other people, but that's not something that I'm doing. And I have a duty, like everyone else, not to violate other people's rights. Other people have duties not to engage in acts of mass violence as a result of my failing to frame this person, and they're violating their duties. But that's not what I need to worry about. I need to worry about my duties and what I do. So that's just a quick description of consequentialism in deontological thinking. I bring it up here because this question about the values that underlie this is put in a way that we could say begs the question in favor of consequentialism. If we aren't consequentialists, we're probably going to think, well, you've missed the point. Right? If you are a consequentialist, you'll accept this. You might be swayed to become a consequentialist when you think about the examples, and that's part of the reason why Rachel's is giving us very vivid, difficult to think about examples. But if we're not swayed, this argument isn't going to work on us because we're just going to reject the idea that the most important thing here is the value involved in alleviating suffering. There's more going on. We have a duty not to kill actively other people. So Rachel's makes two main claims about the practical effects of holding the difference thesis. First of all, preventable suffering will occur. And second of all, we will make what he calls questionable compromises. It almost seems like Rachel's might be more sympathetic to someone who didn't believe that passive euthanasia was okay either, right? Which is another way to say that Rachel's denies the difference thesis, and one way of dealing with a denial of the difference thesis is to say that both passive and active euthanasia are acceptable in some cases. Another way of dealing with it is to say they're both unacceptable. Rachel's doesn't like the position in the middle because he thinks it leads to compromises that don't really have good grounds. They don't make sense. I mean, of course, he prefers it to option 3. When he doesn't like it, I mean philosophically. There's something about it that he thinks shows some faulty reasoning. To further illustrate the preventable suffering associated with the moral difference thesis, Rachel's next considers infants that are born with Down syndrome. I mentioned this case already. In some cases, Down syndrome is accompanied by a treatable intestinal blockage. And when this occurs, some parents choose to forego the needed operation, letting the infant die in the belief that its life is not, on the whole, worth saving. So there's a thought that an infant with Down syndrome, if we have a chance to let it die, some parents choose that because they think that will actually, on the whole, alleviate suffering. Because the thought is, it is bad to have Down syndrome. It causes suffering. We can agree with that statement. We can disagree. That's not the point here. The point here is that some parents decide this. Rachel's thinks that this decision to let the infant die, as opposed to actively killing it in such a case, leads to a lot of unnecessary suffering. The infant could receive a lethal injection. It could be put out of its misery. Instead, the infant is left to starve to death and suffer infections. So it's painful for this infant. Rachel's is saying, look, if we think that the infant doesn't have a life worth living, why don't we just actively euthanize it? Why are we waiting for days for it to suffer? Again, Rachel's is saying this because he thinks that the moral difference thesis is false. And so we are making a moral decision with massive consequences. Much more suffering occurs than is necessary or than would otherwise occur, and we're doing it on the basis of a distinction that is irrelevant. Rachel's tries to make the case very vivid because he believes that by letting us see the case in detail, we might be moved to reject the moral difference thesis. When surgery is denied, the doctor must try to keep the infant from suffering while natural forces sap the baby's life away. As a surgeon whose natural inclination is to use the scalpel to fight off death, standing by and watching a salvageable baby die is the most emotionally exhausting experience I know. It is easy at a conference, in a theoretical discussion, to decide that such infants should be allowed to die. It is altogether different to stand by in the nursery and watch as dehydration and infection wither a tiny being over hours and days. This is a terrible ordeal for me and the hospital staff, much more so than for the parents who never set foot in the nursery. So a doctor's report. When we do ethics, methodologically, one very persuasive story of what's happening is that we look at examples and we look at principles. The idea being that all of us have certain intuitions about example cases, and all of us have probably formulated some principles about right and wrong. And if we are responsible, philosophically, what we try to do is bring our principles and our intuitions about examples in line with each other as much as we can. So I might hold the moral difference thesis as a principle. What Rachel's is trying to do here is get me to have a strong feeling about an example so that I will be forced to reject the principle. Because all of us, insofar as we are rational, try to avoid dissonance of this kind. Right? We want our principles and our intuitions about cases to be in line, and therefore, if we find out that our principle and our intuition about a case like this are at variance with each other, we're either going to have to maybe try to lessen our intuition, attenuate it, or find some reason not to take it as seriously, explain it away. We think this, but it's really not relevant, because not everything that we feel in the final analysis is something that we ought to feel, right? So sometimes, for example, you might have beliefs about your own value, your own worth, that are tremendously low. And there, the thing to do is not to use those beliefs as data, but in fact, to find some way to disregard or change them. Right? So we might, when forced to acknowledge a difference between our principles and our intuitions about particular cases, we might take the route of trying to work on our intuitions about the particular cases. What Rachel's is doing here with these extreme examples is trying to get us to see why that is unreasonable, why we can't stomach it. It's hard to ignore what he has just told us if we hold on to the moral difference thesis as a principle. This is the kind of thing we are signing off on. The last criticism of moral difference thesis is that it leads to decisions made on what Rachel's calls completely irrelevant grounds. And this is really well illustrated by the Down syndrome case. So when he discusses this case, Rachel's notes that the moral difference thesis leads doctors and loved ones to make important decisions on grounds for reasons that are irrelevant. What Rachel's points out is that if the infant's life is truly not worth preserving, this is because of the Down syndrome, not the internal blockage. Right? If a baby was born just with an internal blockage, every doctor would cure that. So the blockage is not the issue. What we care about is the Down syndrome. And we can decide that that is a non-issue and think this baby can have just as good of a life. We can provide it with love and care and support so that it develops and this infant will be happy and be a happy child. Or we can decide that having an infant born with Down syndrome is ultimately not a good idea. Children with Down syndrome don't tend to live terribly long, and their lives do include suffering that other lives perhaps don't. So the point is that whatever we decide, the thing that's relevant to our decision is going to be the Down syndrome. It's not going to have anything to do with the intestinal blockage. That's an accidental thing that just happens to be there. Therefore, the presence or absence of such a blockage in any given case should not determine the infant's fate. It's almost like a lottery. Right? The Down syndrome is what we care about, and we hope that there's a blockage if we think that the infant is better off not living. Rachel says, this is absurd, no matter what view one takes of the lives and potentials of such infants. Again, if you think that the life of such an infant is worth preserving, what does it matter if it needs a simple operation? Or if you think Down syndrome is so terrible that such babies may be allowed to die, then why does it matter if some babies' intestinal tracts are not blocked? Right? So in the case where the intestinal tract is blocked and we decide that we're going to let the infant die, if another infant with Down syndrome is born without that blockage, Rachel's just saying, look, moral principles need to be universal, and if the relevant factors are the same in two cases, you ought to come to the same conclusion. What he's saying here is that the relevant factor in the case where we let the infant die with the intestinal blockage was not the intestinal blockage. It was the Down syndrome. Now, if we look at a baby without the intestinal blockage, but also with Down syndrome, if the relevant factor in the first scenario was the Down syndrome, and the Down syndrome is present in the second, then the universality of moral judgment should require us to have the same conclusion about both. Because the intestinal blockage is not relevant. It's, in Rachel's mind, just as relevant as the color of the baby's eyes. Right? So it's like we were saying, well, when the baby has brown eyes, then we'll let it die, and if it has blue eyes, we won't. That's an irrelevant difference. Now, I mentioned something about universalizability of moral judgments. This is basically the idea, and I think all of us employ this in practice, that if there are two situations where all of the morally salient factors are identical, there's no morally relevant difference, then we have an obligation, rationally speaking, to make the same decision in both cases. Now, that doesn't mean that we will. It's rather a rational constraint. To compare what's being said here, there's a similar constraint when it comes to something like artistic beauty. If I look at a painting and I deem it beautiful, and then I look at a painting that is identical, everything about it is the same in terms of its material characteristics as the first painting, we would think that I was somehow missing something important if I said that one was beautiful and the other wasn't. And if I said the first one's gorgeous, the second one's ugly. That doesn't make sense, because beauty is a property that supervenes, that is determined by the physical makeup of the thing. And so if two paintings have identical physical makeups, it doesn't make sense to say that one of them is beautiful and the other isn't. You could say both are beautiful, both are ugly, both are meh, somewhere in the middle. You can't say that there's a difference. If there is a different frame on the two, that would be probably an irrelevant difference. And so you couldn't say on the basis of the frame that one of the paintings was ugly and one of them was beautiful. Of course, you might think with the frame there, you might mistake that the fact that they're identical. But when it's pointed out that they are identical, your judgment of the two paintings should be the same. You might lament the frame in that case. But there's a pressure to only look at artistically relevant features in the artistic case. Likewise, in the moral case. If there are two actions, one of them is done by a 31-year-old, one of them is done by a 32-year-old, all of their moral features, morally salient features, are identical. Moral universalizability says that we ought to have the same judgment about both. Okay? That's what Rachel's is getting at here. But the main important point is that Rachel's thinks the Down syndrome is irrelevant because he thinks the difference between killing and letting die is irrelevant, between active and passive euthanasia. So the person who believes in the difference between active and passive euthanasia, they're not going to take the sort of straw man position and say that the Down syndrome is relevant. Rather, what's relevant is the difference between what actions are taken or not taken in both cases. The Down syndrome is just the occasion. Right? So it's important to see when someone is maybe making claims about what other people think that those other people wouldn't endorse. Right? And it's not the case that most people who do endorse the difference thesis are going to say, oh, well, the Down syndrome is the important thing. Right? And the fact that Rachel's acts like it must be that has to do with his consequentialist leanings. Right? Because if you don't imagine that the moral status of the action has only to do with the consequences, then there's something that you can say which isn't the same as saying the Down syndrome is relevant. And that's what I just said. The relevant difference is in what is done in each case. It's not about the consequences of what is done alone. It's about what is done, because there are duties that attach to acting and not acting in certain ways, and those also determine whether or not actions are acceptable. So Rachel's position, I've already tried to specify it to some extent, as the opposite of the moral difference thesis is the moral equivalence thesis. Moral equivalence tells us that passive and active euthanasia are morally equivalent. Rachel says, I will argue against the prevailing view that active and passive euthanasia are morally equivalent. There is no moral difference between them. By this I mean that there is no reason to prefer one over the other as a matter of principle. The fact that one case of euthanasia is active while the other is passive is not itself a reason to think one morally better than the other. My argument will not depend upon assuming that either practice is acceptable or unacceptable. Here I will only argue that the two forms of euthanasia are morally equivalent. Either both are acceptable or both are not. They stand or fall together. So here we have is not itself a reason. That itself is related to the intrinsic language that we saw before. So the idea here is, in any given case, there might be other factors that go along with the active euthanasia or passive euthanasia that make, in that case, one of the two actions okay and the other one not. What Rachel's is denying here is that that difference between two actions is ever going to come down to the difference between active and passive alone. So there could be cases of active euthanasia that aren't acceptable and cases of passive euthanasia that are, but it's not going to be because of that difference. Notice also that Rachel's clearly states that he's not arguing that either one of these is okay or not okay. It's rather that they both stand or fall together. So to specify his thesis more precisely, moral equivalence holds that there is no intrinsic moral difference between active and passive euthanasia. The fact that an action is an instance of active euthanasia does not make that action morally worse. Again, intrinsic. Notably, the moral difference thesis, again, I just said this, but it's worth stressing, does not claim that either active or passive euthanasia are in fact permissible. Instead, it tells us that there is no moral difference between the two practices, considers as such. So again, I'm stressing this point for the same reasons I stressed what Velleman's thesis actually is and what it isn't in the last two lectures. Because it's really important when we're evaluating an argument to understand what conclusion is being argued for. And having taught this paper before, I know that some students might be inclined to say that Rachel thinks that active euthanasia is fine. He doesn't say that in this paper. So you got to be careful, regardless of what he thinks outside of this paper. Whether or not one supports euthanasia in general, then, one should take the same attitude towards passive and active euthanasia. Either both are permitted or neither is permitted. And that doesn't mean that both are going to be permitted in every case, right? Again, there are going to be a lot of factors that, when we're looking at an individual case, are going to make a difference. And how we look at all those factors and how they add up is going to change the moral status of an action in a given case. Rachel's claim is that the difference between active and passive euthanasia is irrelevant, like the baby's eyes, or like the fact that, say, a painting. So let's go back to the two painting comparisons. Imagine that one of the two paintings on the backside that you can't see has a number 3 on it, and the other one on the backside that you can't see has a number 2 on it. If we're really assessing the aesthetic value of both paintings, the 2 and the 3 are not going to make an intrinsic difference to the aesthetic value, to whether this painting is beautiful or not. That's what Rachel's wants to claim about the difference between active and passive. It's irrelevant. So Rachel's wants to argue for the moral equivalence thesis. When we're making ethical arguments, as I said, we rely on our grasp of different principles. We also rely on our intuitions about different cases. And when someone is trying to convince us to change our view, one thing that they often have to do is try to allow us to see why the thing that we already have a certain intuition about maybe is a case where our intuition is misguided. Okay? Now, moral equivalence is rejected by a lot of common sense. We ordinarily think, and Philippa Foot will make a lot of good points and examples to point this out, to show this. We ordinarily do think there's a difference between killing and letting die. We think it's worse, as Philippa Foot will say, to send poisoned food to people who are starving than it would be to simply not send any food. They're going to die in either case, but we somehow think it's worse to send poisoned food, and in fact much worse than it is just to do nothing. It's worse for me if it's a freezing cold night and I see someone who's homeless to dump water on them so that they freeze to death than it would be for me simply to pass them by. They freeze to death in both cases. The case where I have actively interfered, we tend to think, in common sense, is worse. Rachel's wants us to agree with him. He has pointed to these examples that almost certainly are going to cause us to question our commitment to the principle of moral difference. One of the things Rachel's can do to help us see that we should change our views is explain why it is that we hold the views that he thinks are mistaken. Okay? So, moral reasoning we can conceive of, as I've said, as in part trying to get our intuitions about particular cases in line with our thoughts about what principles are true. So we have rules that tell us killing is wrong, and then we have thoughts about cases where someone is killed. Okay? Rachel's has tried to show us cases that maybe we don't think about that are going to give us intuitions that strongly conflict with our ordinary embracing of the moral difference thesis. What he's pointing out here is that, in fact, part of the reason we believe the principle of the moral difference thesis isn't because it follows straightforwardly from intuitions that are not confused, but instead because we have a certain confusion that comes from the kinds of cases we normally see. Okay, so Rachel's is basically saying the sample set that allows us to think our principle of moral difference thesis is correct is in some sense or other not a good one. So he's trying to explain why we think the moral difference thesis is true in a way that doesn't require it to be true. So to make clear what I'm saying, Rachel suggests that we reject the moral equivalence thesis because the ordinary cases of killing we see, our sample set, are generally worse than ordinary cases of letting die. And what Rachel thinks is that even though that is true, if you look at the ordinary cases of killing we hear about and the ordinary cases of letting die that we hear about, one of them are generally much worse than the others. Rachel thinks the reasons that make that difference in the cases we are familiar with are only accidentally related to the distinction between killing and letting die. So, to go back to the painting case, imagine I think that the painting with the number 3 on the back is way more beautiful than the painting with the number 2 on the back. That's irrelevant. Why might I think that? Well, maybe, and here's the accidental part, maybe every beautiful painting I've seen so far in my life has just accidentally happened to have a number 3 on the back. Or, let's say I'm talking about basketball players, and I pick my favorite basketball player on every team, and I just pick whatever player has the number 33. Well, that's irrelevant. Now, maybe part of the reason I do that is because in the first few cases I saw, the best player on the team just happened to have the number 33. That would mean that my sample set was misleading. And so now I think 33 is always my favorite, when in fact, there's no reason. There's nothing intrinsic to having the number 33 that makes you better or worse. Or maybe I saw somebody with the number 33 punch someone else, and now I don't like anybody with the number 33, right? It's irrelevant because it was an accident. So what Rachel's is saying here is that if you look at what data we are exposed to when we think about cases of killing versus letting die, ordinary cases of killing involve bad motives, right? Because we turn on the news, we see murders and things like that. They have bad motives. There are murders over money, murders that are crimes of passion. Someone's cheating on someone else and there's a murder. There are murders of rage, road rage, right? These are all bad. And part of the reason why we have a strong reaction to these is because we think the people are motivated in bad ways. Ordinary cases of letting die, if we hear about them at all, are going to be motivated generally, not always, but in many cases they're going to be cases of passive euthanasia. And so they're going to be motivated by a desire to alleviate long-term consequences that are bad. Now, there are some cases of letting die that are really egregious because of negligence, right? If someone doesn't feed a child in their house because they are too strung out on drugs or something, that is something that is going to make us think that that case of letting die is really egregious, right? But Rachel's point here, which I think is quite strong, is that there's a certain constant conjunction that is accidental. It doesn't have to be the case that every time there's a case of killing, there are bad motives. But in actual fact, most of the cases of killing we see are of that sort. This constant conjunction of morally negative factors that goes along with the bare distinction between killing and letting die makes us falsely conclude that there's something worse about killing in itself. And if you're having trouble grasping what this is saying, go back to the case where someone is looking at the two paintings. They think that having the number 3 on the back makes a difference. We're telling them that it's irrelevant. One way that we could get them to see that is by pointing out, look, every painting you've seen just as a mere coincidence. I mean, it's not a coincidence in the case of news items because they're telling us about these cases because most cases of killing actually do have bad motives. What Rachel is saying here is that they don't have to, right? So if someone thinks that the number 3 is relevant, we can say, look, that's just because of some fluke. And then we could show them lots of beautiful paintings that don't have the number 3 on the back. Rachel's is saying something similar to that here. We make a false conclusion because we've only ever seen something that makes us think that this is bad. So Rachel says, we learn to think of killing in a much worse light. Most actual cases of killing are clearly terrible. Think of the murders reported in the newspaper. And we hear of such cases almost every day. On the other hand, we hardly ever hear of a case of letting die, except for the actions of doctors who are motivated by humanitarian concerns. So we learn to think of killing in a much worse light than letting die, and we conclude invalidly that there must be something about killing which makes it in itself worse than letting die. But this does not follow, for it is not the bare difference between killing and letting die that makes the difference in these cases. Rather, it is the other factors, the murderer's motive of personal gain, for example, contrasted with the doctor's humanitarian motivation, or the fact that the murderer kills a healthy person while the doctor lets a terminal patient racked with disease die, that account for our different reactions to the different cases. So he also points out that most cases of murder involve healthy individuals. And most cases of letting die that we hear about are cases of passive euthanasia, and so the individuals are sick. Right? What Rachel's is saying here is that, yeah, there are these certain connections between the cases that happen and the cases that we see, but there's nothing about the distinction between killing and letting die that makes one of the two worse. It's always going to be accounted for by one of these other factors. So what Rachel's wants us to do is overcome the effects of constant conjunction. In order to overcome the effects of the accidental constant conjunction of killing with bad motives and bad consequences, we have to discuss cases where the difference between killing and letting die is the only relevant variable. So that's what Rachel's wants to do. We can do this by setting up contrast cases in which two agents perform the same action for the same motive with the same consequences, and the only relevant difference is the one between killing and letting die. This will be the Smith and Jones bathtub example that we'll get. In active and passive euthanasia, Rachel tellingly compares this procedure with scientific methods aimed at figuring out the importance of factors underlying physical interactions. So what we want to do is isolate variables. In the sciences, we often want to know what influence is exerted by one element in a complex situation. The familiar procedure is to isolate the element of interest by studying cases in which everything else is held constant, while that one element is varied. Children are taught this idea in school by having them perform simple experiments. For example, does the color of a combustible material affect whether it will burn? Children can see that it does not by trying and succeeding to burn bits of paper of different colors. Does the presence of air affect combustion? Most of us will remember placing a candle in a bell jar and watching it go out after the oxygen is consumed, while a similar candle outside the jar continues to burn. By varying one element, we see what difference it makes. Right? So this is the idea of a controlled experiment. Right? We hold everything else fixed, and we allow only a difference in the variable that we want to test for. So to have his controlled experiment, Rachel's introduces the case of Smith and Jones. And these two cases are meant to be identical in all of the morally relevant respects, while differing in only that feature that is important. And that is going to be whether or not the agent is active or passive when it comes to their contribution to the outcome. Now, both of these are cases where someone is allowing to die or killing for a motive that is clearly bad, right? So both of these figures are awful. And this makes both cases different from that of euthanasia. Both of the cases are identical with the difference of active and passive agents. Why would Rachel's make these cases where the agents have bad motives? In both cases, the agents have motives. Something to think about. Why is that good as a thought experiment? Why is that a good feature to make these cases different? Well, it's a good feature because we want to figure something out about the case of euthanasia. And if we're going to learn something new about euthanasia, we can't just look at two cases of euthanasia because we already have intuitions about the importance of activity and passivity in those cases. We might agree with Rachel's or we might not. But Rachel's wants to convince people who don't already agree. And since they don't already agree, if we show them cases that are just the original case, they're going to have the same response. So we need something different. And why not make it quite different so that none of our intuitions about euthanasia are going to carry over? They're less likely to because of similarity. Right? So these are two cases where the agent has a bad motive. Both cases have the same outcome. A child dies. Perhaps we have the death of a child because that is supposed to make us feel a particularly strong reaction. Okay? Now, I think that what is going on here actually might be harmed, might be less informative in terms of answering the question because it's a child. Any idea why that might be? Well, if we have really strong intuitions, it might be that our intuitions about both cases are so strong that maybe they overload our ability to really say which one of these is worse, right? If a reaction is so extreme, it can sometimes be the case that it's harder to tell the difference, at least when it comes to physical interactions, right? Like if you're in a really large amount of pain and then it doubles, that's probably not going to be as noticeable to you as it would be if you went from some lower threshold to pain to some higher one, because you're already overloaded. So anyway, there are certain similarities and differences between this case and the euthanasia case. Let's look at the cases. Smith stands to gain a large inheritance if anything should happen to his 6-year-old cousin. One evening while the child is taking his bath, Smith sneaks into the bathroom and drowns the child, and then arranges things so that it looks like an accident. It sounds like a mystery novel to me. Jones also stands to gain a large inheritance if anything should happen to his 6-year-old cousin. So he sneaks into the bathroom planning to drown his cousin. In this case, however, he enters the room only to find that the cousin has slipped and fell and is already drowning. Delighted, Jones lets the child die, prepared to push the child's head back under if he should come up for air. So here we have two cases. And in one of the cases, the agent is taking an action. Right? In one of the cases, the agent is actively drowning and then afterwards makes it look like an accident. So that would be the active case. In the other case, the agent sees that the child is already drowning. The agent plans to drown the cousin. Also, the agent is the sort of person that could actively drown, right? The agent is prepared to push the child's head back under if he should come up for air. Now, maybe if it came down to it, Jones would not be able to actually carry out the killing, and Smith would. And if that's the case, that might be a reason why we have a more favorable assessment of Jones's character. Regardless of what we say about the action itself, and this is something to think about as well, there are sometimes, or at least some people argue, that there is a difference between evaluating the moral status of an action versus evaluating the moral status of a character, of an individual, in terms of their character. Those of you who have done some Aristotle will know that Aristotle is very interested in evaluating individuals in terms of their characters. Even if we are consequentialists and we think that the right action is always going to be determined by the consequences, it might still be that there's a separate question about who's a good person, and it might be that some people are not good people because of some little things that they do, For example, maybe they cut someone off in traffic. It's innocuous. It never hurts anyone, never leads to a death. This person could, though, if the circumstances were different, could be more likely to really harm someone, to murder someone even. Right? Little things might add up. Maybe someone's just a little ruder. This is exaggerated, but what I'm saying here is that we can evaluate characters in terms of things that we think are important for figuring out who we want around, and we have a different standard perhaps for evaluating actions. Here, though, it looks like Jones is being said to be willing to do the same thing as Smith. So let's just pause for a second and look at the two examples, because they're well constructed. If we think about what a thought experiment is supposed to do, which is to isolate an important variable and to give us a new situation that has features that are the same as our target situation, but that is different enough that we're not going to carry over our intuitions about the target situation to the new situation. If that's what we're looking for in a thought experiment, then how is this a good one? It's a question, right? Is this a good one? Well, it is, because it has lots of features that, first of all, are different from our from our original case, but also Rachel's has gone out of his way to make the two situations similar in the important respects. So both of them have the same motive, right? Both of them are planning to kill before they kill. So both of them are the sorts of people that plan killings. Both of them, counterfactually, would have murdered if they had to. Jones is delighted when he finds that he doesn't need to murder, but presumably, and really I think Rachel's could have made his case even stronger, or even, maybe not stronger, but more equivalent. Maybe it would have been an unnecessary detail had he pointed out that Smith was also the sort of person who would have been delighted to see the child drowning, because then he wouldn't have to kill. Now, we don't know why Jones is delighted, but he is the sort of person who gets delighted when he sees a child die. So, this case, we are supposed to look at it. We're supposed to think that the only important difference is that in one case, the agent is bringing about the action, bringing about the outcome by acting. So in one case, the agent is bringing about the outcome by taking an action. In the other case, the agent is bringing about the outcome, so to speak, by not acting. And if we want to make a neutral description, we could say in both cases, the fact that the outcome occurs, in one case, it's a result of someone actively intervening. This is similar to what Foote says about this. There's an ongoing process only because they started it. So they're actively causing something to happen which is going to bring about that end. And in the other case, the agent is making sure that outcome occurs by not doing anything. So this is supposed to be two cases where we've isolated the variable. It's an interesting thought. It's an interesting thing to think about. Are these actually the same? Like, Jones is delighted. Smith, we don't find. Notice that in the Smith description, Smith isn't happy about the fact that the child dies. It leaves it open. And so maybe we can reserve in our head some idea that Smith is indifferent. Jones, we know, is somebody who's delighted to watch a child drown. Also, if Jones were to push the child's head back under, if the child tries to come up from air, I suppose that's it's at least as bad as murdering, because it is murdering. But then that's also going to be murdering a child who almost drowned and then miraculously saved themselves. Now, remember, what we're looking at here is our intuitions about these cases. And Rachel wants us to say that our intuitions are the same, that we feel like both agents are equally bad. And one thing I mentioned as a potential factor that might cause trouble is the fact that we're murdering a child or letting a child die. And when it gets to very extreme cases, especially those involving children, what do you think our reactions are going to be like? They're going to be more extreme, aren't they? Think about any offense against children. Like someone murders a child. If someone kills a child, that's obviously really bad. I think that person, though, is obviously already at that point in the worst moral category. If they now murder a second child, of course that's worse. But I think that it's harder to imagine that the action is that much worse, or the agent. So I've been focusing on the agent, but even the action. I mean, of course, in the abstract, I think that we do think that, of course, 2 being dead is worse than 1. I mean, when we get to a certain point, isn't it also true that when we add larger and larger numbers, that it doesn't seem like the difference of adding an extra number is as significant? So, for example, say on September 11th, 1 more person had died. Now think about a murder that happens in your general area, your town or something. 1 person is killed. Now we add, and now it's 2 people. It's worse, I think. I think the addition of 1 person, I don't know. So what I'm thinking about here is just different ways that we might react to different presentations that maybe on consideration we wouldn't think represented our considered moral judgment. So I think that a person is a person and that every human life is going to be equally valuable, right? And so it's a problem if I don't conceptualize, morally speaking, if I'm not as sensitive to additions at the margin that involve much higher initial quantities, right? So that would be a reason to worry about my intuitions. They're less sensitive. Anyway, so my claim here, or my suggestion, is maybe the fact that this is a child actually serves to cloud our intuitions. Maybe if we made this a case where the act was less egregious, maybe we wouldn't have the same intuition. Now, remember here also that all we care about is the status of the action. I've talked about ways in which the agents might be thought of as different, but that's not important here. We only want to think, or we hope we only want to consider, whether one of these actions is wrong and the other one is right. The reason I talked about factors that might make us think that the agent is worse is because when we examine this case, it's hard to hold apart, I think, and this is true even if we know that this is going to happen or might happen, it's hard to hold apart our evaluation of the action from our evaluation of the agent. I think for me, it's difficult. And so if there are factors that do make me inclined to think that one of the two is a worse agent, I might start to think that the action is worse, right? For that reason. And so it's important to point this out. There's one thing that we might do, which is ask who is a better person. There's another thing, which is which action is better than the other, right? Which is a better action. And what I'm saying is that things can blur. And things can blur for good reason if we think that virtue ethicists are onto something, because virtue ethicists actually think that unless you're a virtuous person, you can't do the virtuous action. And so what you do isn't necessarily praiseworthy. I mean, it is, because we want to get you to continue to do those things, but it's not a virtuous action. So if you have a view like that, the blurring I'm talking about is reasonable, comes from your theory even. Even those of us who don't have that kind of moral theory, though, we're going to, I think, be susceptible to this. So anyway, we have these two cases. In both of them, we have an agent with a bad motive. One case, there's a drowning. The other case, there is an accident. So Smith and Jones, according to Rachel's, behave in morally equivalent ways. Rachel's claims that Smith and Jones behave in morally equivalent ways and that neither action is any worse than the other. He also believes that readers will share his intuition. Right? Therefore, he concludes, having had this intuition, and we're supposed to have it with him, that the bare difference between killing and letting die is not morally significant. And he argues on these grounds that there is no intrinsic difference between active and passive euthanasia. And if there is some trouble seeing how what he just did is an argument for the claim that there is no difference, because remember, that's his thesis, this is his argument for it, but it's not an argument in terms of necessarily clear premises and conclusions. What it's an argument in terms of is showing us two contrasting cases, and we're supposed to feel some way about them. And that's supposed to make the argument. And remember, he compared this to the scientific method. So we don't feel there's a difference, and that is an argument for the claim that there is no difference of a certain sort. It isn't really the case that the fact that there's no difference in this case is evidence for the conclusion, in the same way that I think one controlled experiment might be. Like, I feel like, we don't need to see 1,000 thought experiments to make sure that this is right. And I think we're more likely to take one as an argument than we would be in a scientific case. If you just have one controlled experiment, you don't know that this vaccine causes, some kind of rare heart condition. You need more variables that are controlled and more data to say that, and more experiments that are slightly different too. Anyway, so we have here the claim that this thought experiment, we're going to have this intuition, and we're going to then accept the argument that there's no difference, because we've seen an instance, and there's no difference there. Thus, it seems that when we are careful not to smuggle in any further differences which prejudice the issue, the bare difference between killing and letting die does not itself make any difference to the morality of actions concerning life and death. Now, again, I haven't read this in a while, and I'm just thinking, like, what would I say about this? And if I were going to try to take this argument down, if I had wanted to object to it, and, it isn't, I don't know. If I were going to find a criticism here, I would definitely go after the careful not to smuggle in any further differences which prejudice the issue. I think that there are issues there. So that's one way that we could go after this kind of argument. There are other ways which we'll see that others have come up with, which are, I think, deeper and more philosophically interesting than what I was doing. And these have to do with just basic observations about what kinds of things such experiments can show. Like, okay, so in this particular case, we might not think there's a difference. Does that mean there's never a difference between action and passion, between watching something happen, not passion, but passivity, watching something happen and not doing anything? Are there no cases where that's a difference? And when we go back to euthanasia, is that a difference there? Because you could think, if you take a skeptical line about this particular thought experiment, you could think that maybe what's happening in the case of active and passive euthanasia is that maybe our reaction is less negative and we are more able to sense minute differences. And if you think about, if you take an evolutionary approach to many of our moral reasoning dispositions, our dispositions for reasoning morally, we're probably going to have a more fine-grained awareness when it comes to people who have done morally good actions. Because morally bad actions, that's a danger. And when we deal with danger, we tend to reason fairly simplistically. So we're going to probably be more likely to just put that person on the shit list, so to speak. And now we've written this person off, and so there's no more thought that needs to be happening. And so we have this dumber category in the sense that it's less sensitive. And when it comes to good people, we can more accurately figure out differences. Now, euthanasia is a place where we might think the action is a good one, and so maybe we're more sensitive. Anyway, there are some categories of offense, particularly those involving children, which I would expect to have a really brute response in us, to produce a really brute response for reasons. Now, this is another way to think about what's happening in these cases that some philosophers like and others don't. But anyway, we have to, even if we think that what I'm describing is not a reason for why it's right to think the way that we think, even if we think that these things are distortions, which we very well might, we need to know about them. Right? So maybe we think that there is an ethical truth, but evolution might make us have a certain cognitive distortion just in virtue of the kinds of things that are likely to be selected for from an evolutionary standpoint. Okay, that's enough for today. The next lecture will finish this off. Have a great weekend.